The BodyTom portable full-body multiple CT slice scanner is revolutionising the quality of diagnostic imaging within the operating theatre. It is a high-quality 32-slice diagnostic imaging CT that is completely portable. With its large gantry aperture of 85 centimetres, it can accommodate even the largest patients. The imaging segment within the gantry contains an X-ray tube and an opposing array of 32 detectors mounted on a ring that rotates around the patient. It has the capability to perform axial, helical and dynamic scans, with slice thicknesses ranging from 1.25mm to 10mm, within a single rotation coverage of 4 centimetres. The standalone workstation communicates wirelessly and has a large range of post-processing functionality, with 3D and planar reconstructions available. The mobile gantry is battery-powered and driven by internal motorised wheels for general transport. Retractable caterpillar tracks are lowered for scanning. It plugs into a standard wall socket to allow for charging. The BodyTom can stay on standby for up to 14 hours or around 4 to 6 hours of scanning time without needing to be charged. Although the system is utilised for diagnostic mobile imaging, it can also be integrated with computer-aided navigation systems for intraoperative navigation. It connects seamlessly with a range of different navigation systems, for example BrainLab, Stryker and Medtronic, just to name a few. Most navigation systems are made up of separate components that interact to allow for 3D real-time navigation. Generally, these components are as follows: a display screen, a navigation pointer probe, a patient array, a gantry array, and a navigation camera. Let's have a look at the overall preoperative procedure using time-lapse imaging. We'll return to the specific segments and discuss them in detail once this is completed. this case, prior to the surgical list, the body tom is driven into the theatre and positioned where the scan will be initiated. The table is raised to the minimum height required to clear the gantry, as shown by the line highlighted here. The radiographer or theatre staff will align the table at this time, and once the proper alignment is achieved, the table's floor lock is enabled. The system components are now optimally positioned to allow smooth workflow once the operation has commenced. The gantry is then parked in position approximately 1.5 metres from the end of the table using the Caterpillar drive system. This is done to clear the surgical area of obstruction until the body tom is required for data acquisitions. Like all CT scanners, a warm-up and air calibration procedure is required. A full warm-up and air calibration takes roughly 8 minutes. This is performed at the beginning of the list to aid in workflow. A follow-up air calibration may be required later in the day. However, this short calibration only takes 2 minutes and can be performed when changing patients. Once the warm-up and calibration has been completed, the patient can now be brought into the theatre and positioned correctly on the table. In this instance, the patient is placed prone on the table with the head towards the gantry. The arms can be placed in various positions. Both arms above the head, as in this case, one hand above the head and one down by the side, this is called the swimming position, or both hands by the side. All of these positions enable the gantry to move smoothly over the patient without obstruction. The arm position is determined by the surgeon, although it is worthy to note that when the hands are by the side, there is additional radiation to the arms when the scan is being performed. Also, with the arms by the side, the surgeon needs to lean further over to access the surgical site, which can be uncomfortable during prolonged cases. The arms are secured via tourniquets to ensure patient safety. The anaesthetic tubes and leads are also secured to ensure they're not compromised when the body tom is brought over the patient. The surgeon will then mark the skin for the proposed incision and fixes the patient navigation array. This can be of the surgeon's choice. The array is fixed to a solid fixation point, in this case the iliac crest. It's very important to have solid fixation of the patient array, as any movement will affect the navigation accuracy. Once the patient array is fixed in place, the table is raised to the minimum height required. The gantry is positioned over the patient and a start position is determined using laser lights. A lateral low-dose scanogram or scout is then performed. This enables the radiographer to determine the limits of the examination, these being the start and finish point for the axial scans and the exposure factors to be utilised. Axial scans are required to comply with TGA requirements for navigation. Once the acquisition is planned, it's very important to enter the start position for the scan to the navigation system, noted on the gantry. It is paramount to get this number correct, as all of the calculations and communications between the various arrays and cameras are determined from this point. The axial CT scan or data acquisition only takes approximately 15 seconds, so the preparation leading up to and after this point is the sole determining factor in the efficiency and speed. Once the acquisition is complete, the gantry is then returned to its original parked position so that the operation can begin free of obstruction. While this is happening, the data set acquired from the body tom is sent to the navigation system. The patient arm board is placed at the end of the table as one unit. This is important as once the surgical component has been completed, it can be removed quickly as one piece to improve efficiency and workflow. The anaesthetist assists with repositioning the arms onto the arm board. Once the data set is received and confirmed on the navigation system, the intraoperative real-time navigation is now available. The surgeon will verify the anatomical levels utilising the navigation probe. Accurately determining the area of interest allows the surgeon to minimise the skin incision required for the procedure. The navigation system has many functions available for real-time imaging. In this instance, multi-screen approach is adopted, allowing for a 3D reconstruction, axial, sagittal and orthogonal projections to be visualised at once. The starting point for the implant screws and various angles can be confirmed prior to probing. Real-time measurement and screen capture can be performed at any time. These images are stored automatically and can be utilised for reference purposes later on. Once all the screws are in place, the surgeon can confirm the appropriate positioning of these devices by performing a post-operative helical scan. The sterile gantry drape and the arm board is removed. The patient's arms are returned to their position above the head and fixed once again using tourniquets. This allows free movement of the gantry over the patient. A sterile drape is then placed around the patient to protect the open surgical site from contamination during the scanning process. The drape is taped underneath in such a way as to allow free movement of the gantry without obstruction. The table is returned to our predetermined height, marked by the line shown previously. The gantry is driven to its start position as determined from the original scanogram. No additional scanogram is required, limiting unnecessary radiation to the patient. The limits of the helical scan are determined by the radiographer, and then the helical scan is performed. This scan takes approximately 5 seconds. However, the whole process from positioning, wrapping and scanning takes approximately 5 minutes. Image reconstruction is immediate and can be displayed on the workstation. Full diagnostic quality results are obtained using this method, and the patient can be assessed within the theatre environment prior to skin closure. Can also be sent to the surgeon's laptop for review. Once the surgeon is happy with the result, the gantry can be parked in the corner of the theatre and plugged in to recharge. The sterile drape on the patient can be removed and the arm board can be reattached. It is at this point that the operation is completed. The data set acquired is retained on the workstation and can be manipulated to provide high quality images, be that multiplanar reconstructions or 3D render, as can be seen from the images here. The system provides unparalleled image quality for navigation and is truly an amazing step forward in intraoperative imaging.